Hello everyone, this is Shadi Reyes from Detroit Medical Center and this is SIF 2022. With me is Dr. Neil Gheewala. He is from PIPA Heart and Vascular and Tucson Medical Center.
Yes.
Neil, always pleasure to see you.
Pleasure to see you. Thanks
see
for
the
having
great
me.
things you're doing, especially in the structural space, proctoring for mitral as well as TAVR. So as an expert, and you are proctoring a lot of different generation of interventionists, there's always a challenge that comes up for structural heart fellows when they graduate.
Right.
How I build, how can I start, from business aspect as well as from complexity of case aspect.
Right.
So let's dissect this question slowly together.
I think, great to see you, Shadi, and thank you for having me. I think, first of all, I think the most important thing as a new fellow, more than the business aspect or anything like that, is getting great outcomes. Go after the easy cases. Go after the ones that are, your P2 prolapse or your central jets with functional mitral regurgitation. Those oftentimes are going to be your easiest cases, and show good outcomes. The better, when you have great outcomes, that speaks more volumes than when you're trained or how many you've done in fellowship, because at the end of the day, the referring providers really care about the outcome. I think functional mitral cases and your P2 prolapses, I think, are your bread and butter cases. Make sure you have cases that have plenty of leaflet length, and that you've had a discussion with the patient about what anticipated results they could expect. And as long as you have that discussion, I think, with the patient, along with the referring provider, those are really tips for success, whether you're brand new to MitraClip or you're fresh out of fellowship. But the outcomes really are what's going to help grow your program.
Absolutely, and reputation and outcome and so forth.
Absolutely, absolutely. And what I think is even, it kind of relates into the business aspect, is that those outcomes are going to be your best business card for future referrals, right? So the one thing that I think is the most important thing that a new fellow can do is, when they get a case, make sure you call the referring provider. Keep them in the loop what's going on. There are so many apps and social media things that you can use to create HIPAA compliant videos that you can send your referring providers as far as what the outcomes look like. Because that way they can see what the pre looks like and what the post looks like. And those also help the referring providers show that to their patients. And give the referring providers a lot of credit, because they're the ones who identified that patient would be suitable for that therapy. So I think from a business aspect, you're dealing with two things. One is the referring provider, making sure that you're getting great outcomes, great communication. But I think the other part's also the hospital. The hospital wants great outcomes because they obviously care about their reputation and their outcomes. But the other aspect of it is that getting these people out the door the next day, or even thinking about same-day discharges, are things that save the hospital some money, and at the same time allows them to invest more into what you want to do to grow the program.
Absolutely, and that's what go into the bucket of marketing yourself and the program, and so forth.
Absolutely,
So this is, we see a lot of fellows kind of want to get out and they're ready to clip, ready to deploy the TAVRs and stuff. So let's talk about a little bit from your experience and what you have seen before. You said easy cases for the mitral, in terms of what are the things you should watch for, what are the things you should avoid doing in the first year of practice.
So when it comes to MitraClips, I think the most important thing is look at what your starting gradient is, look to see how big your valve orifice area is over 4, make sure you have plenty of leaflet length. And as long as you're somewhere in the middle of the valve and you're clipping not near the commissure, at least your first 10 cases, those are going to set you up for a really good outcome. It's the cases that are, your P1s or P3 prolapses that are oftentimes can be challenging. Those can be done successfully through edge-to-edge repair. It is something that you can do, but I think that there's at least a 20 case learning curve to be able to address those as well, because the worst thing you can do is get stuck below the chordae, below the valve. And that requires sometimes a lot of maneuvers to get out. And I think that as long as we stay away from those cases, that would be good. Cases that have a lot of MAC and short posterior leaflets, those are also cases in the beginning. Make sure you have plenty of leaflet length and you're meeting everything by the IFU.
So on the same aspect, like when they interview for a job and stuff, imaging is becoming a close partner for the interventional, especially for the mitral. So how they quote-unquote negotiate or look up for that partner before they jump into a new job?
In terms of
as an imaging, non-invasive sonographer or invasive imaging cardiologist.
Well, I think individually as a structuralist, I think you should be a great imager. That should be one of the things. So I encourage all structural heart fellows, make sure you're board certified ANCO, make sure you feel very comfortable with TE, and then when you're working with a non-invasive cardiologist, make sure you respect their opinions. I mean, because at the end of the day, when you're doing this procedure, everybody's opinion matters, right? Because at the end of the day, they're all here to support the outcomes. And so work closely with your non-invasive cardiologist, and they will help guide you. If they know what the pitfalls are and what you're looking for, and you can communicate during the case, they're going to help you get those outcomes.
Right. Yeah. And in terms of, let's move on a bit to the TAVR space.
Yeah.
What is new? It's TAVR becoming like almost a very conventional therapy now.
Yes.
Especially for low, intermediate, and high. But what is new? What is in upcoming? The challenges that we should look for in difficult cases.
Yeah. So I think the biggest issue I think in TAVR right now is low risk patients, right? So we're FDA approved for to offer TAVR to people over the age of 65. That's based on the guidelines. And low risk, but not all low risk are created the same, right? There's a low risk patient who's 77. And then there's low risk patients who are 65, right?
Yeah.
And I think the biggest thing that I think one of the bigger advances is saying, well, how do we set these patients up for success, right? Who's a great valve and valve candidate for the future, or TAVR and TAVR candidate? Should some of these younger patients who are low risk, should they undergo a bioprosthetic valve first, and then have a TAVR in the future, or vice versa? If they're very young, do they undergo a TAVR and then a prosthetic valve, and then a TAVR inside a prosthetic valve? Those are all things that we're trying to sort out right now. Cerebral protection, again, in the younger population, it's very important, right? Because the long-term implications of the cerebral sand, as we call it, things we shower to the brain, there's a lot more long-term implication for somebody who's younger than older. So that's another question we have to investigate. And then, of course, the intraannular valve versus supraannular valve, right? So we have, two valves that are on the market right now. We have the Edwards SAPIEN 3 Ultra, and we have the Medtronic Evolut R. One is intravalvular, one is supravalvular, and both have their advantages. But Accurate Neo, that's a current trial that's going on through Boston Scientific, and that is open to all risk cohorts right now, and it's randomized against your choice of a standard of care valve, a commercial valve, and the Accurate Neo valve. And so, again, looking long term and saying what is the optimal valve for these patients as they need future interventions, making sure they have coronary reaccess. So I think that we're certainly going to be curious to see what the Accurate Neo outcomes look like as the trial continues to enroll, and how that fits in our current algorithm with using the Evolut R and the SAPIEN 3 Ultra.
It's funny you mentioned, or not funny, it's interesting that about the younger age they are more, or at least we should protect them more from the emboli.
Absolutely, yeah.
Although they are younger, you assume you're going to be less chances
right.
of embolizing.
Exactly. But we know we have plenty of data even showing, let's say, children who are undergo cardiac cath, that if you do MRI studies on them, it shows that there is some element of showered emboli that happen just from doing a transcatheter procedure. So to say that we're going to take something that's 16 French potentially going over the arch, and again, all these leaflets that we have, we don't fully examine the leaflets, right? So what emboli can break off that we don't have that answer.
Yeah.
We're really excited to see the protected TAVR results, which that study was looking at the Sentinel cerebral protection device. That trial has recently completed enrollment, and that data has been analyzed and will be presented.
Awesome.
But I think it's going to be something that, again, as we look at our there's the patients that are high risk, and it makes sense to use a Sentinel, but I think really the implications in your low risk cohort, because what we can do to make sure that long term these patients do well.
Yeah. So last comment about the SIF. What do you think now this year? It's fully open.
It's exciting. It's exciting to be back in person. Exciting that we can all interact and continue this educational forum together. We appreciate everyone's done to bring this together again and to be back better in life.
And it's funny you mentioned that, because we follow journals, we follow webinars and stuff, but we got some fatigue from that. And when you come to this meeting, you get a bolus of education. And different perspective, like what I hear from you now about the low risk and others.
Right.
It's completely different.
And the thing is that you're right, because there's one thing you can do on camera, or there's something that you can do through in journals, but then there's the interaction about experience, right?
Yeah.
Like what you you see in your practice, right? Those are things that we can learn from, and vice versa. So I think those are things that really kind of, as we go back to our home institution, something we can take back with us.
Absolutely. Well, Neil, always nice to talk to you.
Shadi, it's always a pleasure. Look forward to seeing you next year, okay?
Thank you so much. Please watch this movie and others on SIF 2020 YouTube channel. This is Shadi Reyes from Detroit Medical Center. Neil, thank you.
Thank you. Thanks.